Hello everyone, my name is Dr. Saloni Shirke and I'm an internal medicine resident at Mercy Hospital Fort Smith. Today I'll be presenting a case about pancreatitis secondary to Cryptosporidium associated cholangiopathy in an immunocompetent adult. Cryptosporidium parvum is an intracellular protozoan transmitted by the fecal-oral route. It is endemic worldwide with significant cause of morbidity and mortality in resource-poor countries. It's estimated that more than 800,000 cases occur in the United States each year. Cryptosporidium is traditionally known for its role in immunocompromised patients. In immunocompetent hosts, Cryptosporidium traditionally causes non-bloody, self-limiting diarrhea. Cryptosporidium has been directly associated as an etiology of pancreatitis. Here we describe a rare case of acute pancreatitis as a result of Cryptosporidium-associated cholangiopathy in an immunocompetent adult. A 64-year-old female presented to our acute care facility with abdominal pain and diarrhea. She lived on a farm and reported working with rescued goats which were recently sick with diarrhea. A few days later, she developed a fever of 102, nausea, vomiting, epigastric abdominal pain, and about 8 to 10 episodes of non-bloody watery diarrhea. Past medical history was significant for cholecystectomy 4 years ago, and she was taking black cohosh for menopausal symptoms. She denied any relevant family history, smoking history, alcohol use, drug use, or recent travel. Labs showed liver function tests elevated in a non-cholestatic pattern, and lipase levels elevated more than 2/3 the upper limit of normal. A stool PCR panel was positive for Cryptosporidium. Fecal leukocytes and leukocyte stain was also positive. A CT scan of the abdomen and pelvis showed dilated intrahepatic and extrahepatic bile ducts with the common bile duct measuring 10 mm and fluid-filled bowel loops suggestive of mild enteritis. An abdominal ultrasound showed common bile duct measuring 10 mm. An MRCP showed cholecystectomy with intra- and extrahepatic biliary dilation, no definite cholelithiasis, and common bile duct measuring 12 mm with abrupt shelf-like termination of the distal duct. An ERCP was performed and demonstrated dilation of the proximal 2/3 of the common bile duct measuring 12 mm with narrowing of the distal third and dilated hepatic ducts. Pancreatic ducts were not well visualized. A sphincterotomy was performed and a 7 cm biliary stent was placed. Biopsy from brushings of the distal common bile duct were negative for malignancy. Triglyceride, ethanol, and IgG4 levels were normal. PCR for HIV and a hepatitis panel was negative. A diagnosis of acute pancreatitis secondary to Cryptosporidium cholangiopathy was established. The patient was treated with nitazoxanide, IV fluids, and antiemetics with significant clinical resolution. Acute pancreatitis is an inflammatory process affecting the acinar cells of the exocrine pancreas with a mortality rate of about 20%. It's most commonly caused by ethanol ingestion, gallstones, or hyperlipidemia, all of which were ruled out in our case. About 10% of cases are caused by infectious etiologies from viruses, bacteria, and parasites. Cryptosporidium is a parasite commonly associated with gastrointestinal diseases. In an immunocompetent host, it causes sporadic, self-limited enteritis with secretory diarrhea that usually resolves in 10 to 14 days. In immunocompromised patients, it can cause chronic persistent diarrhea. Extraintestinal manifestations including cholecystitis, cholangitis, hepatitis, pancreatitis, and in rare instances, pulmonary involvement have been described in patients with CD4 count of less than 100. AIDS cholangiopathy is a syndrome caused by chronic inflammation of the biliary tree leading to stricture formation and ensuing biliary obstruction. The diagnosis is established with imaging modalities which show characteristic findings of multifocal strictures and segmental dilations of the bile duct. Biliary specimens can be obtained for histopathological evaluation to rule out secondary causes including malignancy. In our case, this was ruled out, establishing the diagnosis of Cryptosporidium-induced cholangiopathy.